Good afternoon, everyone. So we'll be starting the next vitreoretina session. I'm Dr. Saurav Verma, your moderator for the day. The, Dr. Santosh Mohapatra is here. Please join us on the dais. The first speaker is Dr. Harshit Budhwa, and he'll be speaking on CSR with POAG. If the first speaker is not here, then I did not see. Can start. The next speaker, Dr. Nishkarsh Bansal, should be ready. Just stay there and start your. Just, the audio video team, the correct presentation is not. Achha, yours is there. Can I help? Sure.
I'm going to present a case presented with CSCR with primary open angle glaucoma. CSCR is an accumulation of fluid under retina, specifically beneath the macula, mainly affects young and middle-aged due to dysfunction of retinal pigment epithelium and increased choroidal permeability. Primary open glaucoma is a chronic, progressive, non-optic neuropathy characterized by optic nerve damage, visual field loss. Early stages are asymptomatic, but later stages show peripheral vision loss. Patient presented with black shadow in right eye since 1 month, which was painless, gradually progressive, which increases in size. He also complained of problem in vision in low light places. He was diagnosed as primary open POAG in 2021, after which patient was instilling eye drop bimatoprost with timolol in both the eyes. Similar complaint presented in right eye in 2016, for which he took some medication which was not available with records. Patient was also on antidepressant and anti-anxiety medications for last 1.5 years. On examination, the best corrected vision was 6.6 partial with correction of 0.5 cylindrical at 90 degree, and near ad was 1 diopter spherical. The NCT was normal and AT was normal. On gonio, it sclerus per in all quadrants, and perimetry shows normal with no visual field loss. On fundus examination, it shows nasal shifting of blood vessels in both the eyes, bayoneting sign was present, and NRR thinning was present. On OCT, RNFL thickness was normal, and it shows CD ratio of 0.8 in both the eyes. And on OCT macula shows CSCR. Clinical impression: CSCR was often linked with steroid use, and steroid can also cause increase in IOP elevation in underlying primary open angle glaucoma and cause worsening optic glaucomatous optic nerve damage. In visual field defects, CSCR causes central scotoma, and primary open angle glaucoma causes peripheral vision loss. Impact of choroidal thickness: in CSCR, it causes choroidal thickness and leakage, while in primary open angle glaucoma, it causes choroidal thinning. Take home message: patient was advised to avoid steroids and monitor IOP closely, differentiate in visual field defects, and patient was advised non-prostaglandin medication, as it can cause increase in choroidal blood flow and cause increased choroidal thickness. And for CSR, patient was advised currently he was advised for observation, and later he can be considered for photodynamic therapy.
So do you think your CSR was caused because of the bimatoprost maybe?
Sir, maybe. Because he was instilling it for way back before.
So there are case reports where bimatoprost has even caused a serous macular detachment. Usually you talk about a cystoid macular edema, but there are 2 case reports. One published in IE also, fairly recently, like 2-3 years back. So I mean, it's a known thing, yes, very rare, but yes, I think probably it's publishable also, because I don't think that a serous macular detachment or a neurosensory detachment after bimatoprost is reported very well in the literature. Good. The next speaker, Dr. Nishkarsh Bansal.
Very good afternoon to one and all. Today I'll be presenting a case of red herring of Arkwitz scotoma. As we all know, glaucoma is a commonly ocular condition characterized by progressive optic nerve damage associated with elevated IOPs. However, certain conditions may present with similar findings, leading to diagnostic confusion. For example, paravenous pigmented retinochoroidal atrophy is a rare condition which can mimic glaucoma, especially when presenting with Arkwitz scotomas. So this case report aims to highlight a rare instance of PPRCA, which was initially misdiagnosed as glaucoma. Starting with the case details, a 58-year-old lady came for routine evaluation with 6/9 unaided vision improving to 6/6 and 6 on anterior segment examination when Harris grade 3 optically empty with early SIMC changes. IOP initially was 22 and 22 in both eyes, gonioscopy opening to scleral spur in both eyes, and on fundus evaluation 0.6 cupping with healthy NRR. After 3 years, patient visited again and IOP at this time was 20 and 19. Fundus evaluation done again revealed again same CDR 0.6:1 with normal findings and normal neuroretinal limb, but visual field revealed bilateral superior Arkwitz scotoma. Hence, patient was called for a follow-up, and on next follow-up, IOP was 22 and 22. And in view of the slightly higher IOP and visual field changes, patient was diagnosed with POAG and started on PG analogs. Patient continued the treatment for 2 years, and again after 2 years was seen. IOP at this time was 19 and 18 with same visual field changes. So over a total span of 6 years, no progression was noted in visual field findings nor even IOP levels. But on a detailed fundus evaluation, what was seen was surprising: pigmented accumulation along the retinal veins, which was accompanied by peripapillary and radial areas of retinochoroidal atrophy. So what is unique in my case, that the scotoma noted on previous visits of the patient exactly matched the atrophic area noted on fundus examination, and no glaucomatous progression was noted in the IOP, visual field or disc changes. Hence, finally the AGMs were stopped and the Arkwitz scotoma did not progress. Finally, the patient was diagnosed with pigmented paravenous retinochoroidal atrophy. Clinical implication, that it is a rare condition characterized by RPE degeneration, choriocapillary atrophy and pigmentation along the retinal veins. The retinal atrophy is characterized by loss of photoreceptor outer segments, outer nuclear layer and inner nuclear layer. It's a bilateral and symmetric condition with an asymptomatic presentation, generally non-progressive or very slowly progressive. Color vision is usually unaffected, and formal visual field testing may manifest scotomas. There is no treatment specific to PPRCA, and while the exact cause remains uncertain, possible etiologies include dysgenetic, dysgenerative, hereditary or inflammatory conditions. However, no systemic diseases have been identified. As of now, CRB1 gene has been detected with patients with PPRCA. Other than that, no significant study has been done for this. This clearly highlights a clear-cut case of red herring of Arkwitz scotoma, where the mind refuses to see beyond the glaucoma, and clinicians should prioritize a thorough evaluation of the entire fundus rather than just only on the optic disc findings to ensure accurate diagnosis and appropriate treatment decisions. And even while the optic nerve head assessment is critical, an isolated disc finding can lead to misdiagnosis, especially in conditions with overlapping features. I would like to acknowledge my teachers and my colleague for the same, no financial disclosure. These are my references. Thank you.
Glaucoma diagnosis as such should be a comprehensive one, which includes all IOP, fundus, disc evaluation, field as well as OCT.
Yes.
So this is very, if it's a case of POG, it will directly fit into it. So definitely with other findings as you have stated, peripapillary pigmentary changes, diagnosis is straightforward. So it should be a comprehensive.
I think it's an excellent case and very well presented. And quite honestly, I've seen patients with healed choroiditis patches being diagnosed as glaucoma just because there was RNFL thinning in that segment. Nobody did a retinal examination, just an RNFL analysis was done and clear-cut red areas are there. So, and quite honestly, in my center also, a similar patient with PPCRA was being diagnosed. There was a good amount of diagnostic dilemma which perturbed us for a lot of time. And then we finally came to the diagnosis that no, this is not glaucoma, just some faint PPCR.
That is what we have seen, that usually we'll see the disc evaluation, disc findings, and based on that we'll just diagnose as glaucoma.
So I think the biggest take home message is of course a comprehensive clinical examination, and your basics do not go away. If there is no damage to the NRR, labeling a patient as a patient of glaucoma should be avoided, or at least should be done with extreme caution. Excellent.
Thank you, sir.
The next presenter is Dr. Marine Anna Raju.
What is there?
She's coming. So the next presenter, please come and sit in the front row. You start, please. Thank you.
Good afternoon, everybody. The case for discussion for today is endogenous endophthalmitis in a patient with myasthenia gravis who was treated with rituximab. Myasthenia gravis is a chronic autoimmune disease mediated by antibodies against acetylcholine receptor, muscle-specific kinase, or other proteins in the neuromuscular junction. Treatment is usually immunosuppressant like steroids, azathioprine, mycophenolate mofetil, but 15 to 20% of myasthenia gravis patients are refractory to immunosuppressant. In those cases, rituximab is a monoclonal antibody against CD20 B lymphocyte, which is considered as an alternative in these patients. Endogenous endophthalmitis is a rare sight-threatening blood-borne infection from primary site elsewhere, commonly affecting immunocompromised patients. The prevalence of endogenous endophthalmitis in South Indian population is found to be 2.6. In the case proper, the patient present is a 45-year-old male who is a known case of generalized myasthenia gravis, status post thymectomy, and was already on intravenous rituximab. At the time of presentation, the patient was already empirically on vancomycin and piptas in view of abscess over the right side of scalp since 1 week and multiple vesicular lesions over his left arm since 2 weeks. Our complaint was a complaint of decreased vision in the right eye since 4 days, which was associated with pain and congestion. On evaluation, visual acuity was counting fingers at 1 meter. Anterior segment showed lid edema, circumcorneal conjunctival congestion. Corneal edema with keratic precipitates and streak hypopyon was noted in the anterior chamber. Posterior segment evaluation showed grade 3 vitritis, along with an elevated yellowish lesion noted supranasal to the disc, extending from 12 to 2 o'clock, which raises suspicion of a subretinal abscess, and the diagnosis was confirmed on B scan, which showed a dome-shaped elevation with heterogeneous echosity superior to the disc. For the same, the patient underwent plasplanar vitrectomy with silicone oil tamponade, and intravitreal injection of vancomycin and ceftazidime was given. The subretinal abscess was not drained in order to prevent any iatrogenic breaks. With this diagnosis, the patient was started on topical and systemic antibiotics along with oral steroids. Concurrently, the patient developed left-sided weakness and MRI brain was done, which showed diffuse ring-enhancing lesion, which was suggestive of cerebral abscess. Culture sensitivity of blood, aspirate from scalp abscess, and vitreous humor showed nocardia fascinia, and the patient was found to be more sensitive to intravitreal amikacin. So, intravitreal injection was given, systemic antibiotics were changed, and a total of ceftazidime and meropenem 7 doses, and amikacin was given for 2 doses. At 1 month follow-up, the visual acuity had improved to 6/36 with complete resolution of subretinal abscess. So what is unique in my case? Even though aminoglycoside class of antibiotics are known to precipitate myasthenia crisis, we preferred giving intravitreal amikacin under close systemic monitoring. Endogenous endophthalmitis post-rituximab infection has not been reported so far. Clinical implication, subretinal abscess is a rare condition and difficult to treat. Nocardia is notoriously associated with abscess formation, making it an important consideration in the divisional diagnosis. So the take-home message in this case is that endogenous endophthalmitis in immunocompromised is not uncommon, but early diagnosis and treatment can save vision. Clinical microbiological correlation is crucial for effective treatment, and not all abscesses require drainage. Thank you.
How do you differentiate endogenous from
So based on the systemic presentation, sir, because in this case the patient had infections in other side which was suggestive that it could be endogenous. There was no history of any other ocular trauma or anything which suggested exogenous origin.
So in this case, how do you think that is endogenous?
Sir, it could be either due to the scalp abscess, and the patient had a cerebral abscess as well. And the scalp abscess showed nocardia, and even the vitreous sample which was collected also showed sensitivity to the nocardia. So it could be secondary to the scalp abscess. The patient could have.
Have you cultured vitreous samples?
Yes, sir. That showed nocardia, which was sensitive to amikacin.
Okay.
Thank you, sir.
Next.
The next speaker, please, Dr. Sunanda Kumari.
Good afternoon, one and all. My case is when retina rebels, a case of neovascular glaucoma in a diabetic patient. Neovascular glaucoma is a potentially blinding condition characterized by formation of new blood vessels on iris and anterior chamber angle. It is commonly associated with diabetic retinopathy, central retinal vein occlusion, and ocular ischemic syndrome. Early diagnosis and management are essential for preserving vision and prevent complications. Case details. This is a 59-year-old male, a known case of diabetes mellitus type 2 and chronic kidney disease, presented with complaint of 1 week of painful vision loss in left eye. He was diagnosed as having diabetic retinopathy on his past ophthalmological examination and advised for required management, but he denied treatment and lost to follow-up. He had history of cataract surgery in both eyes 8 years ago. There was no history of trauma to his eyes. On ophthalmological examination, vision in right eye was 612 and in left eye it was hand movement. Other finding in right eye was normal except fundus, where changes of the diabetic proliferative retinopathy was seen. And in left eye, there was circumciliary congestion and corneal edema was present. In iris, there was neovascularization. Pupils was semi-dilated and reaction to light was sluggish, and intraocular pressure was 49 mm of mercury, and on gonioscopy, Cephas grade 1 with neovascularization of angle. And on fundus examination, there was changes of the proliferative retinopathy with cup disc ratio of 0.5. Up to this examination, patient was diagnosed as a case of neovascular glaucoma. So for management, for elevated IOP, intraocular pressure of the patient was treated with intravenous mannitol with anti-glaucoma medications. Topical steroids and cycloplasics was also administered. He was also followed up with the endocrinologist for his glycemic control. He received an intravitreal injection of the bevacizumab, but desirable IOP was not achieved, so trabeculectomy with mitomycin C was done. This is a picture showing the vascularization along the pupillary margin in left eye. What is unique in my case, this patient was previously diagnosed at early diabetic retinopathy stage, which can be managed easily. But this patient showed negligence and lost to follow-up and presented when jumped to the dreaded complication. Clinical implication, diagnosis of neovascular glaucoma can be made clinically. It is essential to examine the iris before dilatation for easy detection of the neovascularization of the iris. Neovascular glaucoma secondary to PDR is a challenge to treatment and result in guarded prognosis. Surgical therapy is needed in advanced cases. Take-home message, this case tells about the importance of the regular screening and follow-up in diabetic patient to prevent dreaded complication. Control of neovascular glaucoma in a diabetic patient is multidisciplinary approach which include medical and surgical management. Early detection and aggressive management plays an important role in the visual prognosis. Thank you.
So well presented. So I have a question. Did you laser this patient?
Yes, sir.
So in your entire presentation, I did not see any part where you lasered this patient. This patient has PDR, right?
Yes,
Yeah,
sir.
at least.
Sir, we don't have facility to laser, so we referred the case up. We manage only in the intraocular pressure, sir. Sir, in neovascular glaucoma, management include two-step control of IOP and control of ischemia. We don't have facility to fluorescent angiography or OCT or laser. So after controlling IOP, we referred the patient to the retina specialist.
So the next question is, would doing a laser before trabeculectomy or any filtration surgery for that matter, would it increase the prognosis or decrease the prognosis? It would make the prognosis better, you know, because
Yes,
essentially when you laser the patient, the NVIs are supposed to regress. So now
Yes.
a patient with an aggressive NVG would rather act like a patient of PACG, depending upon what amount of closure of angle has already happened. So if you ask me, if a patient of NVG comes to me, and even if I'm sitting in a peripheral center where I don't have the facility of laser, of course I will start him on maximum tolerable anti-glaucoma medication, and I'll send him for quick laser within a week or so. After and in the meanwhile give an anti-VEGF injection so that there is quick regression of NVI, and then plan this patient for a subsequent filtration surgery so that the success rate of the filtration surgery itself goes high. So when you, quite honestly, if you ask me, though the literature says that the success rate is maybe 85% or 90% in 1 year, practically I have not seen any surgeon replicating 90% success rate in an NVG case, that too without lasering the patient first.
Yes.
Yeah, it will worsen the patient. So you have to laser the patient first. Otherwise,
Basic.
after TRAB, it is very difficult to laser also. You don't want to touch the cornea. You don't want to put the lens over the cornea. You are very much perturbed about damaging the bleb, loosening the sutures that you have applied during the TRAB. So it's laser first and filtration surgery second. That is the newer concept. Of course, the older concept was to treat the IOP first and then maybe keep on lasering the antiviral. So, please.
No, you have to laser. Basically, basic treatment.
It has to be lasered.
Do a angiogram, do a
Preferably
laser.
it has to be lasered
Treat
before the
the-
filtration surgery also. Eventually, everybody will say it has to be lasered, but preferably before a filtration surgery.
Yeah. Thank you.
Thank you.
Next. Call.
Okay, so next speaker, Dr. Shini Joglekar. And the next speaker, Dr. Shushmita, please be here at the dice. Thank you. Okay, the next.
आप सर यहाँ आ जाइए because आइए
Dr.
ना,
Shushmita
मुझे
can
जाना है
start
4
with
बजे।
the-
आइए please
She'll be presenting on subretinal hemorrhage with RRD in IPCB. Please upload the presentation here. Or you can whatever.
Good afternoon, everyone. I'll be presenting a case on rhegmatogenous retinal detachment with massive subretinal hemorrhage in idiopathic polypoidal choroidal vasculopathy. So, 84-year-old male presented to us with sudden onset loss of vision and floaters in left eye since 15 days. The patient was a known case of diabetes and hypertension. He had undergone both eye cataract surgery 10 years ago. He was a known case of bilateral IPCV, which was confirmed on ICGA. The ICG of left eye, here you can see a single polyp, whereas the ICG in the left eye showed multiple polyps along with the subretinal hemorrhage. The fluorescein angiography in both eye revealed RPE window defects. The patient received multiple anti-VEGF injections and focal laser in both eye. 1 year later, the patient presented to us with a BCVA of PL positive, PR accurate in left eye. USG was done in the left eye. It revealed numerous small size vitreous echoes with retinal detachment. On fundus examination, here we can see the left eye vitreous hemorrhage. So a provisional diagnosis of left eye retinal detachment with vitreous hemorrhage in a case of bilateral IPCV was made. A 27 gauge transconjunctival sutureless vitrectomy with removal of the subretinal blood, fluid air exchange and injection ranibizumab with silicone oil infusion under LA in left eye was planned. Here in the surgical video, we can all see that the core vitrectomy is being performed. After which, bullous RD along with the subretinal blood was noted. Thorough inspection of the peripheral retina was done, and a tiny flap tear at 2 o'clock temporal periphery was noted. From here, removal of the subretinal blood was done using the active suction of 27 gauge cutter. As the break was located in the extreme periphery, complete removal of the blood was not possible. Therefore, we made a retinotomy inferonasal to the disc, and from here the remaining subretinal blood and fluid was removed from the posterior pole. Here we can see the blood, the remaining subretinal blood is being removed, and the retina is getting settled over here. It was then followed by fluid air exchange, which was then followed by endolaser around the retinotomy and the primary retinal break, which was followed by injection ranibizumab and silicone oil injection. So post of 6 weeks, the OCT revealed thickened scar and overlying thicker retina with subretinal fluid adjacent to the scar, and the fundus showed traces of hemorrhage adjacent to the scar. Post of 5 months, OCT showed resolution of the subretinal fluid and reduced retinal thickness, and the fundus showed resolution of the subretinal hemorrhage. This is a very unique case because of combined rhegmatogenous retinal detachment with massive subretinal hemorrhage, which did not require any fibrinolytic agent for liquefaction. Subretinal blood could be removed completely, almost completely. IPCV is very similar in presentation with neovascular AMD, but it is characterized by massive submacular hemorrhage, and ICG is the best diagnostic tool for it. Patients presenting to us with features of AMD and showing suboptimal response to anti-VEGFs must be evaluated early and promptly to rule out IPCV to prevent irreversible vision loss. Thank you.
Why did you use ranibizumab? Why didn't you use brolucizumab or aflibercept?
So already we used brolucizumab and aflibercept, and we gave multiple anti-VEGFs injection earlier. So the patients...
No, it's not the first line of treatment. The choice of anti-VEGF in PCV is either aflibercept or brolucizumab.
Yes, sir. We initially gave it in the trial, but during the surgery, the patient requested because already it was not affordable for the patient.
Second thing, why do you think there was liquefaction of the subretinal blood?
Sir,
Usually not there when the retina is active.
yes, sir, because there was a rhegmatogenous retinal detachment, which lead to the leakage of the in the subretinal space. The fluid leaked in the subretinal space, which led to the liquefaction. Like the blood was not clotted.
And what was the time period from subretinal hemorrhage to the intervention, surgical intervention?
So,
because lysis will only occur after 2 weeks of bleed.
Yes.
So what was the time period for that?
So from the diagnosis to the intervention.
Yes.
Sir, earlier we gave the anti-VEGF.
In your case.
Particular case.
So 1 year.
No. The time period between the subretinal bleed and your intervention.
Your intervention.
Oh, it was more than 2 weeks, sir.
Yeah, that is the time. What 2
Yeah.
weeks is the time when the lysis of
Lysis of blood occurs.
That is one of the reason you didn't require tissue
Tissue
plasminogen
plasminogen
activator,
activator, sir.
and the blood came out only with the cutter.
Yes, sir.
So I have another question. Your first clinical image that you showed had peripheral subretinal hemorrhage, right? In the inferior temporal cortex.
In the left eye.
So why isn't this a case of Pecher? You had a peripheral subretinal bleed. Although it falls in the same category, but still it is a distinct entity. I would have probably labeled it as Pecher to begin with.
Because it does not look like after settling of the retina.
So
It's one and the same thing. Peripheral, it's a polyp only.
Yeah.
So it's a one and the same thing.
it falls in the same pachychoroid spectrum.
Yeah, pachychoroid.
Nice case.
Thank you so much, sir. Thank you.
So the next speaker is Dr. Tavish Gupta. Acha, Dr. Sheni, are you ready? So Dr. Sheni will be presenting her case, false alarm choroidal granuloma event.
Slides are not moving. Slides are not moving. Causes of choroidal masses. It can be metastatic tumor, primary choroidal tumor, inflammatory condition or infectious conditions. 48-year-old female presented with sudden diminution of vision in right eye since 3 days associated with fever, loss of appetite and cough. Best corrected visual acuity in right eye was 6/18 and left eye was 6/6. Anterior segment examination in both eyes were normal. Right eye fundus examination showed yellowish white choroidal elevated lesion with ill-defined margin and subretinal fluid. Left eye fundus showed pigment alteration and PED in macular area. So, provisional diagnosis was right eye querychoroidal granuloma and left eye querypachychoroid pigment epitheliopathy. On OCT right eye, we saw undulating RPE Brooks membrane complex, neurosensory detachment and subretinal hyperreflective material. Left eye showed PED with pachyvessel. Right eye USG showed medium to high internal reflectivity with choroidal mass. In 3 days later, patient visited us with reports. These were the reports, and the fundus we saw, there was less apparent choroidal elevation. We were shocked to see there was decrease in height of RPE elevation. FFA revealed choroidal hypofluorescence, and we could see ink blot leak. So this was suggestive of typical CSC. Left eye FFA was showing pooling corresponding to PED. So, rapid reduction in 3 days points to the possibility of loculation of fluid in posterior choroid. We arrived at the final diagnosis as right eye acute central serous chorioretinopathy with localization of fluid in posterior choroid presenting as choroidal elevation and left eye pachychoroid pigment epitheliopathy. Pulmonology opinion in view of HRCT was given and positive Mantoux test, but there was no evidence of pulmonary TB. So we suggested patient about observation and dorzolamide eye drops. After 2 weeks, patient presented with significant decrease in subretinal fluid, and after 6 months, there was complete resolution of subretinal fluid with unaided visual acuity 6/6. Accumulation of fluid in the outer choroid in eyes with CSC is known. According to literature, 64 to 67% of patients with CSC can have this. But what is unique in my case is, even in eyes with localization of fluid in outer choroid, the RP is flat with no undulation or elevation. Our case depicts that localization of fluid in posterior choroid presenting as a choroidal elevation which lead to diagnostic dilemma. There was only one case report like this in 6 eyes of 3 patients. So the clinical implication, though the diagnosis of central serous chorioretinopathy is straightforward, it can present with atypical features. Due to advancements in OCT, localization of fluid in posterior choroid is identified as a common finding in CSC. It can rarely present as choroidal elevation. Thorough clinical examination and multimodal imaging are required to confirm the diagnosis. Take-home message is, though localization of fluid in posterior choroid is common in eyes with CSC, it can rarely present as choroidal elevation mimicking a choroidal mass.
There is an entity called dome-shaped maculopathy. So what is the differential? Why don't you consider as dome-shaped maculopathy?
Sir, because FFA we had done.
The dome-shaped maculopathy presents like this. Go and read, and you'll find it's similar. Like the only thing with dome-shaped maculopathy is it is done resolves like this.
Okay, within
that
3
is
days.
the difference. Yeah.
Okay.
So go and read about it.
Also, dome-shaped maculopathy will be seen in pathological myopia, where the dome is itself located in the stylomatous area. Yeah, that is very excellent case. I've never seen anything like this.
Good afternoon. I am Dr. Tavish Gupta, and I will be speaking about the great Mimickar. Presenting a 46-year-old male with left eye painless progressive diminution of vision for the past 4 to 5 days associated with a central defect in the visual field. There was no similar episodes in the past, and the patient had a history of pulmonary TB in the past. On examination, the right eye anterior segment was within normal limit, and the left eye best corrected visual acuity was 3/60 with a few AC cells and retrolental cells present. On fundus examination, in the right eye, we can see multiple pinpoint circular creamy white lesions, and in the left eye, we can see disc hyperemia and the nasal margins were blurred. We can also see a geographical area of ground glass translucence of the retina with some punctate creamy colored retinal lesions associated with it. Now on zooming in, we could also find perivascular exudation also present, and these findings were confirmed on the fundus autofluorescence, in which the geographical area is well delineated with hyperfluorescence. On macular OCT, we can see multiple hyperreflective dots more in the outer layers with disruption of the outer layers, broadening of the RP excrescences, and hyperreflected dots in the choriocapillaris, which was confirmed in the peripheral OCT also. Now we have a patient with papillitis, retinitis, and vasculitis. But as in this patient, we have a characteristic retinitis, and mostly the causes of retinitis are infectious. So we should first rule out infective causes before going to other causes. Now the infective causes can be neuroretinitis, viral retinitis, toxo, TB, or syphilis. And if infective etiology is not elicited, then we move on to the inflammatory causes. For neuroretinitis, although our patient had retinal and disc involvement, but our patient also had peripheral involvement and an absence of any macular hard exudates. So we ruled it out. Now for viral retinitis, our patient did not have any confluent 360-degree lesions near the posterior port, nor did he have any hemorrhages. And for ARN also, the patient did not have any characteristic opaque white lesions. So we ruled viral retinitis out. The patient also did not have any focal retinitis with extensive vitritis above it, nor did he have any granuloma. So we ruled out toxo and TB. But the patient had yellowish placoid lesions with vasculitis and a ground glass retinitis. So then we went back to the history and asked leading questions, and the patient revealed that he had a history of genital ulcer a few months ago with papilloerythematous lesions, and he had multiple sexual partners in the past, and his wife also had multiple skin lesions. Now, ocular syphilis can present in a wide variety of manifestations, the most common of which are posterior and panuveitis, especially the acute syphilitic posterior placoid chorioretinopathy, in which there is ground glass retinochoroidal lesions due to the indirect immune-mediated hypersensitivity to the Treponema pallidum. And the fundus autofluorescence and OCT features of our patient are similar to those described in literature for ocular syphilis. Now the patient and his wife were investigated according to the reverse sequence syphilis screening algorithm and were found to be VDRL and TPHA positive. And so, according to the SUN working group classification, we came to a diagnosis of ocular syphilis. And all patients of ocular syphilis are treated on the lines of neurosyphilis. So we treated our patient with injection ceftriaxone, and our patient improved in the lesions in both the right eye and the left eye with an improvement in the visual acuity to 6/18. And this resolution was confirmed on fundus autofluorescence also. So the uniqueness is the clinical features which are found in our case, the ground glass rendered translucence and the creamy white lesions and the characteristic OCT and FAF patterns. And the clinical implication is that ocular syphilis should be considered in the differentials for atypical lesions, retinal lesions, due to the ability to mimic various inflammatory and infectious conditions. And the ophthalmologist has a major role in the early diagnosis. And the treatment is supposed to be a multidisciplinary management on the lines of neurosyphilis. Thank you.
Nice presentation.
Your take-home message what is your take-home message from this case?
So the take-home message is that in any case, syphilis can present with any inflammatory condition. So in any case of posterior uveitis, we should have a low threshold for testing for VDRL and for keeping syphilis as a differential diagnosis.
All cases of
posterior
should be tested for syphilis. That is a take-home.
Yes.
Thank you.
Thank you.
The next speaker is Dr. Vatsala Kanwar.
Good afternoon, everyone. The topic for my presentation is a misdiagnosed case of optic disc pit maculopathy. Optic disc pits are considered as part of a spectrum of congenital cavitary anomalies of the optic disc. They are rare and occur equally in men and women with an estimated incidence of 1 in 11,000 people. Optic disc pits, ODPs, are usually single, oval-shaped depressions at the optic disc. They are most commonly found at the inferotemporal aspect of the optic disc, but may be found elsewhere too. Optic disc pit maculopathy is a term used to describe macular changes that occur in context of an optic disc pit, which include intraretinal and subretinal fluid accumulation and retinal pigment changes causing visual deterioration. Case details. A 19-year-old student presented to RIMS OPD with the chief complaint of diminution of vision in the left eye for 2 years, watering for both eyes since 1 year. History of presenting illness. My patient was apparently well 2 years back when he noticed diminution of vision in his left eye, which was gradual, progressive, and painless. No history of type 1 diabetes, hypertension, trauma, COX, asthma, foreign body, and night diminution of vision was seen. For this complaint, he visited a local practitioner where he was diagnosed with left eye CSCR. For this, he was prescribed lifestyle modification, topical medications, and 1 year ago, he also received 3 anti-VEGF injections, but he didn't get relief. So he visited RIMS OPD for the same complaint. He has no significant past medical or surgical history, no significant family history. Personal history, the patient had adequate sleep for 8 to 9 hours. Patient is on mixed diet, regular bowel and bladder movements, no conflicts between family members. General examination, where he was average in build, fair in nutrition. Systemic examination, everything was within normal limit. Ocular examination, in the right eye, the visual acuity was 6.6, whereas in the left eye, it was 660, and the BCVA was also 660. Rest, everything was within normal limit. On fundoscopy, in the left eye, the media was clear, the optic disc was vertically oval, cup disc ratio was 0.3, pink in color, grayish spot seen temporally at the disc, suggestive of optic disc pit defect. The foveal reflex was dull for the left eye, and a round, well-delineated, localized serous macular detachment was seen. Rest, everything was fine, and the right eye was also normal. This is the fundus photograph. So my professional diagnosis is left eye optic disc maculopathy. The investigations were done. The patient was advised for the treatment, but the patient refused the treatment and was lost to follow-up. This was the OCT of the left eye. The fact that optic disc pit maculopathy is a rare disease with the prevalence being just 0.1% is the unique thing about my case. ODP-M can be misdiagnosed if the optic disc is not examined properly. Clinical implication, patients with ODPs that are diagnosed incidentally should be counseled on the risk for development of ODP-M, although rates vary from 25 to 75% and there is no known trigger for it. Patients should be encouraged to return for examination in any case of visual deterioration in the affected eye. One should always do a detailed examination of the optic disc. Limited vitrectomy with intraretinal fenestration is a recently described technique. The most important issue is to discuss the ODP-M patients in whom surgery has been recommended is that the visual recovery is a slow and long process. Thank you.
So very well presented. For all the students present here, so probably it was, this patient was seen outside, in some outside center. Somebody gave 3 anti-VEGF injections to this patient. I mean, it's quite sad, honestly.
Yes,
very
sir.
well presented advice. Yeah.
Thank you, sir.
Dr. R.P. Singh, can you come on the dash, please? And then I'll request Dr. Vinita Vijayan. Dr. Vinita Vijayan, is she here?
And Dr. Rishabh Bairagi can be ready here.
Yes.
And the AV team, please make the PPT present here.
अरे भाई ऑडियो विजुअल वाले दूसरा बुला लो अगर नहीं हो पा रहा है
Okay.
विनीता विजयन ऋषभ
Dr. Rishabh, you can start with the presentation.
Rishabh can start. You can check your presentation there why it's not rolling.
Please.
ऋषभ का कर दीजिए AV team. क्या हो रहा है तुम्हारा इस पे?
पिछली वाले का है.
ये किसका आ रहा है?
Last one, sir.
This is the last presentation.
ऋषभ बैरागी. ऋषभ का प्रेजेंट उधर है.
ओपन नहीं हो पाएगा तब तक.
आप वहाँ पे चेक कर लो कि क्यों नहीं आ रहा तो then you can present next here. You can start.
Good afternoon. Today I will be presenting the management of a case of cataract surgery complication. We have a 76-year-old male, diabetic and hypertensive, who presented with pain, redness and loss of vision in his left eye after undergoing cataract surgery 2 months ago elsewhere. His significant findings were in the left eye, a BCV of PL positive, PR accurate. He had corneal decompensation with iris prolapse, a flat anterior chamber. And what was surprising was that there was a crystalline lens in the anterior chamber, as can be seen in this image, along with corneal decompensation. A USG of his left eye showed retinal detachment. He was subsequently started on topical anti-glaucoma, steroid, antibiotic and cycloplegic medications, and we reached a provisional diagnosis of left eye decompensated cornea with anterior displacement of nucleus, total retinal detachment with severe proliferative vitreoretinopathy. He was taken up for surgery. At first, wound reconstruction was done with repair of iris prolapse, followed by anterior vitrectomy, removal of vitreous strands. Nucleus was prolapsed into AC and it was removed with the help of irrigating vectis. Followed by that, AC maintainer was introduced, membrane dissection was done, and severe anterior PVR changes with closed funnel RD was noted. Again, a surprise, an intraocular lens was seen lying on the retina with one haptic subretinally. Membrane was dissected and it was removed. Now, due to poor visibility, we could not proceed further, and a decision of optical PKP was taken. The patient was taken up for OT 10 days later. Optical PKP was done, and an 8 mm graft was placed with interrupted sutures. Because of choroidal effusion and anterior displacement of retina, through limbal approach, repair of RD was attempted. PFCL was injected, but the retina could not be settled because of presence of fixed fold. So PFCL was kept in situ, and 2 weeks later, the patient was again taken up. Through pars plana approach, it was seen that the retina was settled at the posterior pole. However, because of thick peripheral folds, retinectomy 270° was done. Further PFCL was introduced and endolaser was done, followed by direct PFCL silicone oil exchange. Post-op 3 months, the patient had a clear corneal graft with no loose suture and the retina was attached. This was a unique case where the crystalline lens was found in the AC and IL was seen on the retina, and it was initially thought to be a hopeless case, but it could be managed successfully.
So, how did you prevented the oil to come in the NTS segment and to touch the cornea? What did you do at the end of the surgery to push the oil behind? Oil touch करेगा ना, केराटोपैथी हो जाएगी, सिलिकॉन ऑयल केराटो ग्राफ्ट खत्म हो जाएगा, तो क्या किया उसमें?
The AC was formed with air.
तो फिर से आ जाएगा, एयर तो एब्जॉर्ब हो जाएगी.
A YACPA was done.
चलो, it's
you do the inverse PI. Basically, you do the inverse PI to prevent secondary glaucoma, and positioning at the time of filling the oil, you make sure that it doesn't come in the anterior chamber. Overfilling should not be done.
It's a super specialty question, so I can't expect you to.
That is to prevent the glaucoma. Inferior PI has to be done. Reverse PI has to be done. But excellent surgery, I must say. Amazing job done. Generally, these cases are discarded and not taken up for the surgery. But amazing, excellent done, excellent work. Good.
Thank you, sir.
Dr. Vidush, you can start with your presentation.
Good afternoon, respected seniors and colleagues. I am going to present a case of retinitis pigmentosa which was misdiagnosed as retrobulbar neuritis. So my case is a female aged 17 years, resident of Delhi, belonging to lower middle socio-economic status. The chief complaints of patient were diminution of vision since last 5 years and headache since last 1 year. On a rapid history of present illness, it was found that the patient had diminution of vision, especially at nights in childhood, which was recognized as the parents by about 5 years of age, but they did not attend any eye clinic for a problem in childhood. The patient had complaints of headache since last 1 year, which was located in the orbitotemporal region, constant, not radiating, not associated with aura, moderate severity, no aggravating factors, and relieved on taking rest. Since last 1 year, the patient started taking treatment and came to our hospital 2 months back. There is no any other relevant history or birth history. Pedigree analysis shows that the other siblings of the patient were normal. General physical examination of the patient is normal. Local examination is normal except for the finding that pupils were sluggishly reacting and vision was severely impaired in left eye, which was finger counting 3 meter, while in the right eye it was 6/36. Funda showed tortuous sclerosed vessels, bony spicules, multiple exudates, optic disc edema, and cup disc ratio was 0.2. Color vision was severely impaired and the patient could read only one slide. This is the fundus examination of the patient. Differential diagnosis of retinitis pigmentosa, retrobulbar optic neuritis, congenital stationary night blindness, and pathological myopia were made. Blood investigations of the patient were normal. This is the OCT scan of the macula showing a foveal contour is maintained in the right eye, while in the left eye foveal contour is not maintained. Cystic spaces were present beneath the fovea. Central macular thickness was 430 micrometer in the right eye, whereas in left eye it was 502 micrometer. Visual field shows severe decrease in visual fields, mostly in the peripheral areas. This is the MRI orbit and brain showing no abnormality. Provisional diagnosis of retinitis pigmentosa was made. Hallmarks of retinitis pigmentosa are nectilopia, which is diminution of vision in the evening and night especially, and visual field defects
more towards the periphery. Fundus examination of the retinitis pigmentosa showed striate of arteriolar attenuation, bony spicule intra-arterial pigmentation, and optic nerve head pallor. ERG is severely diminished in retinitis pigmentosa. This is the difference between retrobulbar neuritis and retinitis pigmentosa. Retinitis pigmentosa presents with low vision since childhood, whereas in retrobulbar neuritis, it presents within two weeks of severe progressive vision loss. Pain is usually absent in retinitis pigmentosa, while in retrobulbar neuritis, pain is present around the eye and increases with eye movements. This is the differential diagnosis fundus photographs. Treatment options for retinitis pigmentosa include genetic counseling, newer gene therapies like Luxturna, Argus to bionic eyes. Upcoming therapy include optogenetics using high-tech goggles. Thank you.
Very well presented.
Thank you.
So we can move to the next presentation by Dr. Shruti Mahajan.
Like,
Shruti Mahajan, then we have Shweta Singh. Shweta Singh is here.
I don't think we have ever seen a patient confusing with the RP
Come
with
forward and
optic neuritis, because the diagnosis and the presentations are entirely different. But this is quite good overview of everything.
Thanks.
Upload kar raha.
Shweta, you can start your presentation if you are loaded. Shruti, you have a problem in present?
Yes, sir, I have actually uploaded in the preview room, but then it has not.
Okay, Shweta, is your presentation ready?
I did upload.
श्वेता सिंह का एवी टीम
Yes.
श्वेता सिंह का प्रेजेंटेशन इधर कर दीजिए
It is
इसके
done.
बाद डॉक्टर नागर क्विन एम या यू कैन बी रेडी यू कैन चेक योर प्रेजेंटेशन इज हियर ऑन श्वेता प्रेजेंटेशन
Yes. Good afternoon, everyone. I'll be presenting on endophthalmitis management in a post-vitrectomy silicone oil-filled eye. So this is a case of an 81-year-old male, retired, hypertensive, controlled on medication, who underwent vitrectomy surgery along with cataract extraction in his left eye 2 weeks back. He presented 2 weeks later with complaints of increased redness in the operated eye, increased swelling of eyelids, and diminished vision for the past 2 days. So about history of present illness, the surgery was primarily done for a large submacular and vitreous hemorrhage secondary to PCV with dense cataract. Surgery included 3-port pars plana vitrectomy with subretinal injection of recombinant tissue plasminogen agent, intravitreal injection of aflibercept, silicone oil tamponade along with cataract extraction and PCIOL implantation. So patient was recovering well. This is the anterior segment and the fundus photograph taken at 5th day post-operatively. Vision was improving to 636. Anterior segment showed no reaction and fundal glow and fundal details were clearly visible. At day 15 post-operatively, patient presented with this anterior segment photograph showing intense AC reaction, hypopyon. The fundal details got obscured and vision reduced to finger counting. So we diagnosed this as post-operative endophthalmitis in a post-vitrectomy silicone oil-filled eye with pseudophakia. The patient was urgently taken for anterior chamber tap with anterior chamber wash. We injected intravitreal vancomycin and ceftazidime. Along with that, we started patient empirically on fortified vancomycin, cefazoline, tobramycin, along with oral Ciplox, that is ciprofloxacin. We sent the tap for culture and sensitivity, which came positive for coagulase negative staphylococcus. Fortunately, this organism was sensitive to most of the commercially available antibiotics. This was the presentation pictures, and fortunately the patient responded to the treatment. We also added prednisolone eye drops, initially in low doses after 2 days of intravitreal injection, and closely followed up. 15 days after the intravitreal injection of antibiotics, patient presented. This is the anterior segment photograph showing resolved hypopyon, improving anterior chamber reaction, improving fundal glow, as well as fundal details now getting to be visible. The visual acuity also improved for finger counting to 636. So endophthalmitis in a post-vitrectomy silicone oil-filled eye is uncommon owing to the antimicrobial nature of silicone oil. Although there is a lack of consensus regarding management, traditional methods involved reoperations to remove oil, administration of antibiotics, and silicone oil reinjection. But recent reports advocate the use of intravitreal antibiotics. So, how is the silicone oil toxic to microbes? The low molecular weight components are toxic to the microbial cell membranes. Also, high surface tension and low permeability limits the movement of pathogens, concentrates them close to the ciliary body and blood vessels, allowing the defense mechanism to act better, and leads to washout of toxins. And because of silicone oil in situ, we choose a minimally invasive procedure despite the obscured fundal view. So take home message, endophthalmitis is a dreadful post-operative complication which requires timely intervention and prompt action. But in a silicone oil filled eye, it is rare due to its antimicrobial nature, and one should have high threshold for vitrectomy in these eyes. Also, tap and injection of antibiotics with close follow-up is recommended in such eye if the need for vitrectomy arises in case of worsening. Thank you.
So how do you titrate your intravitreal doses in silicone filled eye?
Sir, when we were managing this patient, we came across some case series and case reports in which we saw whether we use the half dose or we use full dose, it makes no difference. There was no incidence of any retinal toxicity related to the intravitreal injections of antibiotics. So we gave full doses. And also because we did AC tap, so the pressure increase was also not found.
If you do an AC tap, you said you did an AC wash in this patient.
Yes, sir.
So if you do an AC wash, silicone oil will not come in the anterior chamber if the pressure goes down. So what did you do to maintain the intraocular pressure at the time of surgery? AC wash? AC जैसे ही तुमने खोला उसको ऑयल तो आगे आ जाएगा ना तो.
Yes, sir. While we were removing the fibrin, we maintained the anterior chamber pressure.
कैसे maintain किया?
So we could have used anterior chamber maintainer, although we didn't use in this case. But thank you.
With Dr. Shruti Mahajan.
Good evening, everybody. Today I will be discussing a rare case of BRAO. Branch retinal artery obstruction is an abrupt diminution of blood flow through a branch of central retinal artery, severe enough to cause ischemia of the inner retina in the territory of the affected vessel. The key features include retinal whitening in the territory of the obstructed vessel. Visible embolus can be seen in 66% of the cases, and the visual field defect that corresponds to the territory of the obstructed vessel. So a 24-year-old male presented to our OPD with the presenting complaints of sudden painless diminution of vision in right eye associated with diplopia since 5 days. He was having slight inferior deviation of the right eye with limitation of right eye movements in the superior and superotemporal direction. Previous documents reveal history of right eye lower lid chalazion INC with intralesional triamcinolone 5 days back. The personal and the family history was within normal limits. On ocular examination, the left eye examination was within normal limits, and in right eye, the best corrected visual acuity was 6/12, near vision 6/10. Lid showed mild ptosis with lower lid swelling. Extraocular movement shows restriction in elevation and dextro elevation. Corneal reflex was 15-degree hypertrophic. Pupil was mid-dilated approximately 4 mm, which was sluggishly reacting to light. And fundus examination revealed localized retinal whitening in the superotemporal area. Perimetry showed inferior hemifield defect. To confirm our diagnosis, OCT and OCTA was done, and the OCT revealed hyperintensity of the inner retinal layer. So we came up to the clinical diagnosis of BRAO with intraorbital third nerve palsy, probably triamcinolone induced. We started the patient on tablet vitamin methylcobalamin 1500 microgram OD and locally on eye drop Nipafenac TDS. 4 weeks following the treatment, the patient's right eye visual acuity improved to 6/6 part, and inductions and versions in right eye showed mild restriction in movement. So what is unique in my case? Strabismus with BRAO post-intralesional triamcinolone for chalazion is a rare complication. The pathogenesis of post-triamcinolone injection caused RAO can be attributed to accidental intravascular injection or penetrating the proximal branches of the artery. Injury to the muscle and or the associated nerve supply at some point along the injection path can cause third nerve palsy. Clinical implication: determining the correct dose of triamcinolone, which should be approximately 0.1 to 0.2 milliliter or 40 milligram per ml before injecting intralegionally. Careful injection techniques to avoid vascular injection of the steroid. These are my acknowledgements. Thank you.
How did you come to a conclusion कि कैलाइजोन में ट्राइमिस्टोन लगा के वो BRA हो गया?
Sir, when we looked out for the fundus examination, it was showing retinal whitening.
Whether it's a coincidence or it's an
Sir,
secondary.
it was iatrogenic actually. Might be while giving the injection, the surgeon went too deep along the floor of the orbit, and that's how we were.
कैलेजियन कहाँ पे इंटर?
Sir, it was in the lower lid. It was supposed to give. It's supposed to be given intralegionally, but then somehow iatrogenically it was obstruct. It was in the vessel. The triamcinolone was in the vessel.
नहीं तो वेसल से BRA हो कैसे हो गया? What is your hypothesis in this?
Sir, I was thinking since in the floor of the orbit there are anterior ciliary arteries, and which are branches of muscular arteries, and also this anterior ciliary arteries have.
नहीं इसका तो सेंट्रल रेटिनल आर्टरी ऑक्लूजन है ना, तो सेंट्रल रेटिनल वहाँ से कैसे इम्बोलाई कैसे गया? भाई BRA में इम्बोलाई जाना चाहिए ना?
Sir, retrograde flow could be possible.
Retrograde कहाँ से आएगा?
So triamcinolone particles would have been deposited in the artery, and there
नहीं तो internal carotid से आएगा ना, वो तो उसकी vascular supply यहाँ से
See, you have already you are injecting it in a more distal branch. So you are saying from distal branch to a proximal branch.
कैसे जाएगी?
फिर again a distal migration. The pathway, I mean, it's not impossible but very difficult.
Hypothesis क्या दोगे आप? ये आप बोल रहे हो पर hypothesis कुछ तो reasoning दोगे क्यों हुआ है इनको? Science is all about reasoning.
Yes, sir.
Okay.
Thank you, sir.
The next speaker is Dr. Nagrakuni M, and she'll be speaking on hemangioma or CNVM.
Kanchita Pandey is the next speaker. Kanchita.
Good evening all. Today's my presentation is on hemangioma or CNVM. So what is choroidal hemangioma? Is a benign vascular tumor of the choroid of the blood vessel layer beneath the retina. It can be of circumscribed, which is solitary, or diffuse, that is associated with Struck-Weber syndrome. Here is a case presentation. We presented a case of 37-year-old female presented with defective vision in left eye for past 3 months. Best corrected visual acuity of right eye is 6/6, whereas left eye is 6/24. History of left eye anti-VEGF injections given 2 times at private hospital 2 months back. On fundus examination of right eye was normal, and left eye revealed an orange-red elevated lesion involving the macula with subretinal fluid. Of other salient features of the FFA showed left eye hyperfluorescence in the foveal region with lacy network of vessels in early phase with increased hyperfluorescence with variable leakage. Left eye OCT shows subfoveal hyperreflectivity with irregular RP lesion and subretinal fluid. Here is the OCT image showing the subretinal fluid and the fundus image showing the orange-red elevated mass. FFA shows hyperfluorescence in foveal region with lacy network of vessels with in early phase with increased hyperfluorescence in the variable leakage. So what is unique? Patient was advised further anti-VEGF injections and photodynamic therapy on further visits. What is unique in my case is choroidal hemangioma is a hematoma that may be present at birth, and majority of the patients manifest symptoms and present in adulthood in 4th decade. They do not metastasize. However, it involves macula and center of vision and is causing a retinal detachment. It is treated to save vision. Always have a differential diagnosis of this type of cases, which is of amelanotic melanoma, central serous retinopathy, choroidal neovascularization, choroidal osteoma. Although choroidal hemangioma is a rare retinal finding, it is important to distinguish from similar retinal and choroidal tumors. Prompt diagnosis by retinal specialist is necessary if any uncertainty exists. When macular subretinal fluid is present, various treatment options are available like argon laser photocoagulation and photodynamic therapy and anti-VEGF therapy. Choroidal hemangioma is orange-red mass, symptomatic during early adulthood, can result in exudative RD, and if vision is threatening, early diagnosis and management is mandatory. Thank you.
Can you show me the FA of this patient? Fluorescein angiogram?
Yes.
AV team, please make the presentation visible on the main screen also.
FA mein, how did you make a diagnosis of choroidal hemangioma in this patient?
Sir, in early phase it was a lacy hyperfluorescence during.
And why there is a block fluorescence? Hemangioma में तो ऐसा block
So
नहीं है।
surrounding edema,
Huh?
edema with the subretinal fluid.
No. Hemangioma is known to cause and diffuse leakage.
Yeah,
and
in
you
late
should confirm
phases,
on ultrasound also. So I don't think so it's in case of
If
hemangioma.
you have a neurosensory detachment, there will be some degree of pooling.
And can you show me the OCT? FA, RP, would you like to comment, Ankur? Ki FMA, is it looking like hemangioma?
Sir,
Can you go back to fluorescein angiography?
Sir, you have rightly mentioned it will lit up on FFA. And then if there is a neurosensory leak, so in late phase there would be staining. So it would look like that it lights up in early phase and the margins get blurry and it's diffuse fluorescence at the fovea because of the late staining of the fluid.
Can you go to colored photograph, please? It's not an hemangioma. It's in CNVM.
And you also treated with anti-VEGF, right?
Anti-VEGF do respond. A third thing is कि you said कि argon laser photocoagulation in macular hemangioma is not the recommended line of treatment. If you are dealing with a macular hemangioma, low dose full dose PDT, is the treatment, but it's not an hemangioma. Next, please.
Yeah, but what the B scan? Have you done the B scan in this?
B scan picture is not.
That is not done because that can also cleanse the diagnosis. It can show the heterogeneous ecogenic status.
Yes. Thank you.
So the next speaker is Dr. Kanchita Pandey. She'll be speaking on Takayasu arthritis. Is she here?
Aishwarya Khaitan is the next.
Then the Aishwarya Kadam.
Last, yes.
Good evening, everyone. Myself, Dr. Aishwarya Kadam from Government Medical College, Nanded, Maharashtra. I'll be presenting on the topic primary angle closure disease with retinitis pigmentosa in 2 of the 4 siblings. Retinitis pigmentosa affects over 1 million people worldwide. It can be associated with other ocular conditions like cataract, glaucoma, maculopathy, etc. So we present a case series here which shows association between PACD and glaucoma and RP. So 2 siblings, a 39-year-old female and a 34-year-old male, presented to our OPD who were diagnosed case of retinitis pigmentosa, and they complained of diminution of vision since childhood and night blindness since childhood. They had a positive family history with their father having similar complaints. On examination, both the patients had vision of 6/60 and N8 in both the eyes. Both the patients had anterior chamber depth of Van Herig's grade 1, and rest of the anterior segment findings were unremarkable with normal axial length on A-scan biometry and had minimal myopic refractive error. On gonioscopy, both the patients had more than 180-degree oppositional angle closure on indentation gonioscopy. The IOP was normal with less than 21 mm Hg in both the patients. On undilated fundus examination, a pale disc with 0.4 CDR with absent foveal reflex, attenuated blood vessels, and bony spicules were seen in both the patients. And both the patients were diagnosed with PACS with retinitis pigmentosa and underwent prophylactic NDR peripheral iridotomy in both the eyes. Subsequently, the younger 2 siblings of the patients also underwent ocular examination and had no evidence of retinitis pigmentosa or shallow AC. This is a fundus photo of left eye of the male patient showing retinitis pigmentosa, and the photo below is a slit lamp image showing Van Herig's grade 1. This is the pedigree chart of the family in which the father is affected with retinitis pigmentosa with 50% of the offsprings suffering with the disease. So what is unique in my case? We are reporting cases of 2 of the 4 siblings who presented with shallow anterior chamber depth and retinitis pigmentosa. Association of retinitis pigmentosa with POAG is a known thing, but with PACD it is rare. A study conducted by Dr. Zia Pradhan et al. Concluded that 6% of the RP patients have PACD of some form, including PACS, that is 2.9%, PAC in 0.7%, and PACG in 2.3% of Indian population. A large population-based study from Taiwan concluded that RP group had 3.64 times higher risk of acute angle closure as compared to control group. RP patients are at a higher risk of developing PACG, and thus gonioscopy should be performed regularly to identify those at risk of PACG. Optic disc examination and perimetry, on just these two examinations, it could be often difficult to differentiate damage caused to optic nerve by glaucoma versus that due to retinitis pigmentosa. Hence, IOP monitoring and gonioscopy play a key role to pick up such patients. Additionally, use of ASOCT and UBM can weigh in on diagnosing angle closure in such cases. Regular ophthalmic evaluation should not only focus on retinal health of RP patients, but also on other potential complications like glaucoma to allow early intervention and better outcomes. Gonioscopy should be part of routine examination for all RP patients to mitigate the risk of glaucoma-related vision loss, as it further compounds the visual impairment that is already present because of the RP. As RP patients often undergo repeated dilated fundus examination, gonioscopy prior to dilatation can prevent any risk of acute angle closure episode. Thank you.
So very well presented, and I got to learn something new, that there is an increased risk of angle closure glaucoma in RP. Thank you. With this, we'll conclude our session. All the speakers can come forward and we'll take a photo together. In the meanwhile, the next session can start.
For the next session based on UVA, I would like to invite Dr. Raspal sir and Dr. Amit Khosla sir.
आ जाओ सर, अरे आओ सर.